pulmonary valve replacements, but because the many excellent studies have been published, and the surgical indication for the patients with first pulmonary valve implantation after total correction of the TOF or pulmonary atresia with VSD has been established by many excellent studies and scientists, including Dr. Lee. So my case is focused on the redo pulmonary valve replacement. So case number 1 is about the 21 years old female patient. The original diagnosis was tetralogy follow with the absent pulmonary valve syndrome. At the age of 22 months, total correction was performed. At that time, the pulmonary valve was implanted with 19 millimeter. And at the age of the 3 years, pulmonary valve reimplantation, because of the lack of the record, I could not understand what to mean the reimplantation, but I think the same valve was reimplanted. After that, 2 times of pacemaker generator changed, and at the age of 10, the patients underwent a redo pulmonary valve replacement with 25 millimeters. After that, the patient visited the Sejong General Hospital. At that time, on the echocardiography, the definite prosthetic valve failure, moderate pulmonary regurgitation, and severe pulmonary stenosis with a pressure gradient of 80 millimeter mercury. From the catheterization study, the mild to moderately elevated left and right ventricle and diastolic pressure. Unfortunately, we did not check her with the MRI, but the CT shows the not so severely enlarged right ventricle. In this case, we performed the operation, the third redo pulmonary valve replacement with the 27 millimeters. The surgical indication for this case is the definite prosthetic valve failure, the severe pulmonary stenosis. But the case number 2, the 20 years old male patient, tetralogy follow, he underwent total correction at 1 year, and 4 years the pulmonary valve, first pulmonary valve implantation was performed. At that time, because of the tricuspid regurgitation, valve repair was performed. And 6 years later, the replacement pulmonary valve with 25 millimeter, and then visited Sejong General Hospital. And at that time, the just mild pulmonary regurgitation, the moderate pulmonary stenosis, but not so severe compared to the previous case. However, the patient shows the moderate tricuspid regurgitation, and echo shows the right ventricle dysfunction. The catheterization study showed a highly elevated left ventricle and diastolic pressure and right ventricle. MRI data shows the enlarged both ventricle, but not so severe. At this time, surgical indication is not, I think, not the prosthetic valve failure, but we performed the redo pulmonary valve replacement with tricuspid annuloplasty. As I said to you, not severe prosthetic valve failure. That means we could wait or delay the operation a little more. Not severe chamber dilatation. However, we could find ongoing ventricular failure, especially in right ventricle, moderate tricuspid regurgitation, and elevated right and left ventricle and diastolic pressure. So was it early, or could we delay the operation? The case number 3 is the 30 years old male patient, pulmonary atresia with ventricular septal defect. At the age of the 6 years, pot shunt was performed, and total correction was performed at the age of the 8 years. And first pulmonary valve implantation, he underwent a PVR with a 25 millimeter Hancock 2 valve. At that time, he shows intermittent arrhythmia, so we antiarrhythmic surgery. And then visited again. So preoperatively, right ventricle atrium and ventricle enlargement, and the echocardiography shows right ventricle dysfunction, and just a mild to moderate regurgitation of the prosthetic valve, and mild pulmonary stenosis, just less than 20 millimeter mercury. Mild to moderately elevated end-diastolic pressure, and atrial arrhythmia was intermittently occurred. The MRI data shows, however, the severely enlarged right ventricle, more than almost 200. So in these cases, we had some difficulties to determine the timing of the operation, because the prosthetic valve is not so deteriorated, but the ventricle chamber was severely enlarged. So should we operation at this time or wait? Operation was performed with the PVR and the isthmus cryoablation at the atrium. As I said to you, no severe prosthetic valve failure, but severely enlarged the right heart and atrial arrhythmia, and also right ventricle and diastolic pressure was elevated. Case number 4 is another, I think, another surgical indications. A 25 years male patient after the BT shunt and Rastelli operation, and 12 years the pulmonary valve replacement, 23 millimeters. He shows just a moderated regurgitation and mild to moderate stenosis. However, he shows atrial flutter and severely elevated end-diastolic pressure on both ventricular area. So, and however, the MRI data shows not so severely enlarged both ventricular chamber. So, but we decided to perform the operation with the pulmonary valve replacement, and also Mays procedure were performed to treat atrial flutter. No prosthetic valve failure, not severe prosthetic valve failure, but we could find a progressive ventricular failure, highly elevated right and left ventricle and diastolic pressure, and also atrial arrhythmia. So the final case is the 30 years male patient. His first pulmonary valve implantation was performed 19 years old with a stentless valve. His previously implanted prosthetic valve shows just a mild stenosis, a treatment of pulmonary regurgitation, but because of the ventricular arrhythmia, he suffered from the syncope a couple of times. But end diastolic pressure of the both ventricle were not so elevated. But the MRI data shows the enlarged right ventricle. Now, these patients, the previously implanted pulmonary valve shows not so deteriorated function, but he suffered from the ventricular arrhythmia because of we think, the enlarged right ventricle. So we replaced his pulmonary valve and arrhythmia surgery at the ventricular portion, and pulmonary artery angioplasty was performed. Not severe prosthetic valve failure, just a moderate stenosis or regurgitation. That means that we could delay the operation. But if we think consider the enlarged right-sided heart chamber and ventricular arrhythmia, some kind of intervention should be needed. So this is case summary of the all 5 cases. So I think that case number 1 is the definite prosthetic valve failure. However, from the case 2 to case 5, there's no definite prosthetic valve failure. However, case 2, the elevated ventricular and diastolic pressure and the tricuspid regurgitation. And case 3, the right ventricle size enlarged and atrial arrhythmia. And also case 4, the severely elevated and diastolic pressure and atrial flutter. In case 5, the moderately enlarged right ventricle and ventricular arrhythmia. So my discussion point is optimal timing or indications of redo pulmonary valve replacement probably be different from the first pulmonary valve implantation indication after total correction of the tetralogy or pulmonary atresia. So what should be indications? So this is definite indication. Previously implanted prosthetic valve failure. However, we should consider the size of the cardiac chamber and ventricular dysfunction, not only systole but also diastolic and right and left ventricle both. And arrhythmia should be also surgical indication or other intervention for treat. Thank you.